As Dr. Suarez said, and everybody in this group knows that peritoneal carcinomatosis is the spread of cancer in the peritoneal cavity. It is usually considered a terminal condition. Obviously, that depends on the histology of the tumor. IV chemotherapy, as you saw from the data that she presented by Dr. Franco, has some efficacy, but is usually not curative. To date, there's still little or no role for radiation. And when I was training, there was really no role for surgery until recently. And Dr. Suarez already presented a lot of the data that has driven our interest in using surgery for what used to be considered a non-surgical problem. And what has evolved is this concept of cytoreductive surgery and hyperthermic intraperitoneal chemotherapy. And the acronym that we use for that is CRS-HIPEC. And this is a combined approach to use surgery and heated intraperitoneal chemotherapy to remove all the visible cancer that we can from the abdomen, and then put hyperthermic chemotherapy into the peritoneal cavity to kill any remaining cancer cells. The most common indications for cytoreduction and HIPEC right now are appendiceal cancers and tumors, pseudomyxoma, peritoneal mesothelioma, ovarian cancer, colon cancer, and it can also be very effective against the palliation of malignant ascites. And so, as Dr. Suarez mentioned, the goal is to, at the time of surgery, is to ideally get a complete tumor removal so that there's no visible tumor left. But if you can't get that, if you can get the tumor down to about 2.5 millimeters of thickness in any area, we would consider that a complete cytoreduction, and we feel like the HIPEC will be helpful in treating that small amount of residual disease. As you can probably imagine, since the peritoneal cavity is one big open space and the cancer cells have access from the diaphragms to the pelvis, this requires a long midline incision, usually from the xiphoid process down to the pubic symphysis. And the cytoreduction can be very involved. Ideally, we try to do what we call visceral sparing cytoreduction, where we don't actually remove organs, but we can. We can remove a lot of different organs at the time of surgery, including parts of the bowel, small bowel, colon. The omentum is very routinely removed. The gallbladder, uterus, and ovaries in women. The spleen, stripping the peritoneum, where there's tumor involved. Doing a total or partial gastrectomy, depending on the histology, and even distal pancreatectomy. So these can be quite extensive surgeries, as you can imagine. And so we need to be very selective. Dr. Suarez mentioned about the selection patient criteria, because again, this is a life-threatening condition with limited prognosis, for which we're thinking about doing a really big surgery that has a significant recovery. So we want to do it in people that we really think are going to benefit from it. And so the selection criteria that we use are, number one, is the patient fit enough to go through the surgery? Number two, as best we can tell before we take the person to surgery, do we think we can get a complete tumor removal? We usually reserve this for a situation where there's no extraperitoneal metastases, but I put a little asterisk next to that. Because with the evolution of modern systemic chemotherapy, we are really starting to see patients who have disease that we can control outside the abdomen. And so in those select patients, we think about using cytoreduction and HIPEC to try to control disease within the peritoneal cavity as well. We used to say no liver metastases, but now we say limited liver metastases. We really try to avoid doing a formal anatomic liver resection, as that usually means that the burden of disease is higher, but also the risk of complications goes up if we have to do an extensive liver resection. But if we're just wedging out a couple of small liver lesions in a non-anatomic fashion, patients seem to benefit from that. Biliary obstruction is a contraindication. It just speaks to a much more invasive disease process in an area that we're not going to be able to cure or clear surgically. So biliary obstruction, limited ureteral obstruction, where if we can remove that section of the ureter and repair the ureter, that's okay. Limited bowel obstruction, again, if a person has multiple levels of bowel obstruction, we're probably not going to clear that disease. And we rely very heavily on imaging studies such as CT scan, MRI, to get an idea if somebody can get a complete cytoreduction. And then Dr. Suarez showed a nice picture of what it looks like laparoscopically, and we often use diagnostic laparoscopy to determine better if a patient or a person is a candidate for cytoreduction HIPEC. She reviewed the Peritoneal Cancer Index. This is important because it helps us be a little more objective in terms of the volume of disease burden that we're seeing. So that way, when we look at a study like the PRODIGE 7 study where they're talking about a PCI, we know what, a PCI of 7 is relatively low tumor burden versus a PCI of 25, what that probably looks like, a much higher tumor burden. Similarly, after the cytoreduction, we try to give ourselves an objective score of our completeness of the cytoreduction. A CC, we call that a completeness of cytoreduction CC score of 0 is no residual disease. If we have that less than 2.5 millimeters, we call that a CC1. We consider that complete and we consider proceeding with the HIPEC. However, if there's any greater volume of disease left behind, we consider that an incomplete cytoreduction. And the studies will show that the completeness of cytoreduction is really important in terms of the success, the potential success of the HIPEC. So this is a very important part of the concept. Why intraperitoneal chemotherapy? It probably seems pretty obvious, but we can give a much larger dose directly into the abdominal cavity than we can through the IV. There is some chemotherapy that's absorbed systemically, but the systemic circulation is protected by the peritoneal blood barrier. We're applying the chemotherapy directly to where the tumor cells are or were, and we're doing it at a time of the least tumor burden. We've just done a complete cytoreduction. So ideally, we're just treating microscopic residual disease that we can't see. And so that's the benefit of putting the chemotherapy intraperitoneally. And then people always ask, well, why hyperthermia? Well, it turns out that actually heat kills tumor cells. Tumor cells are more sensitive to heat than normal cells. And so we can use the cytotoxic effects of hyperthermia to target the tumor cells. We also know that it makes the tumor cells more sensitive to the chemotherapy, or works synergistically with the chemotherapies that we use, so the chemotherapies are more effective. It's been shown to increase the depth of penetration of the chemotherapy at the time of the HIPEC. And we're also starting to see some evidence that it may work through an immunologic mechanism where, when we do HIPEC, the patient's core temperature really gets up over 38.5. And so they have a fever at that time, and there may be an immunologic component to the response that we're seeing, but that's relatively new and there's more to come on that, but it's kind of an exciting thing to think about. The chemotherapy agents that we use have to be large molecules that do not cross the peritoneal blood barrier too extensively. Obviously, we want them to synergize with the heat, and we want them to have some effectiveness against the cancer that we're treating. So the most common agents that we use are mitomycin, particularly for GI tumors, carboplatin for the peritoneal mesotheliomas, the ovarian cancers. Oxaliplatin, you heard mentioned, has been a big one until the results of the PRODIGE 7 study. Cisplatin, doxorubicin, and melphalan are also other commonly used chemotherapies for HIPEC. If you look at the literature at HIPEC, you'll see that it can be given over a wide variety of times. The PRODIGE 7 study, as Dr. Suarez pointed out, used oxaliplatin for 30 minutes. Most people use 90 minutes, and the reason for that is in order to harness the cytotoxicity of hyperthermia, there is a time and temperature threshold. So the temperature needs to be above 40 degrees centigrade, and the minimum time is 90 minutes. So that's what we use. That's what most people in the U.S. use. Some centers use 2 hours to make sure they're getting past that minimum threshold. We monitor the core temperature very carefully so that it doesn't go above 39.5 for an extended period of time. We've done studies looking at the impact of the core temperature and have found that if the core temperature goes above 39.5 for an extended period of time, there's actually a higher risk of complications and morbidity. So we monitor that very carefully. And during the HIPEC, we literally stand there and shake the abdomen back and forth while the chemotherapy is circulating. I don't have pictures of it, but we actually use a pump. There's a catheter that brings the chemotherapy into the patient's abdomen and then takes it, and then another catheter that takes it back to this external pump that heats and circulates the chemotherapy through the abdominal cavity for 90 minutes to 2 hours. As you can imagine, these are big surgeries. We do all the surgery up front, and then once we get a complete tumor removal, we treat the abdomen with the heated chemotherapy. So these surgeries on average are about 8 to 12 hours. If you look to the literature to see the risk of complications, it can be quite high depending on how rigorous you are about measuring complications. And so the morbidity can range from anywhere to 15 to 75%. Major morbidity, as calculated by a score that we use in surgery, is usually in the order of 15 to 30%, even in high volume centers and in this day and age. Mortality, as Dr. Suarez mentioned, is not insignificant. And in the early reports, you would see rates as high as 15%. Now it's more in the 1 to 2% range at high volume centers, such as in the PRODIGE study. And, when I'm talking to patients about this, about the length of stay in the recovery, really the length of stay for us is about 6 to 7 days here. It's driven largely by the ileus, waiting for the ileus that people develop after the surgery to resolve. And the recovery, I tell people, is measured in months. I tell people if, they're eager to get back to work, it's going to be at least 2 months before they're really thinking about getting back to work, and then even then part-time. So that's why, for all these reasons, we need to be very selective. Again, we are treating, a terminal condition with a limited prognosis for a lot of these tumors. And we want to, if we're going to use this, we want to use it most in people that we're going to help, that we think are going to benefit the most from it. So there is some literature, as Dr. Suarez has already presented. There's also some lay literature. This was from the New York Times back in 2011. There was a debate at the ASCO meeting between Dr. David Ryan, who's the chief of hematology oncology at the Massachusetts General Hospital, and Dr. Paul Sugarbaker, who's really the greatest pioneer of cytoreduction in HIPEC. And it was interesting. It made the front page of the New York Times. There was a lot of discussion around it. At the time, Dr. Ryan really felt strongly that people should only be having HIPEC in the context of a clinical trial, but quite honestly, the genie was already out of the bottle at that point in time. And patients come seeking HIPEC, and that's why it's been very hard for us to do a randomized control trial in this setting, because when patients come to see me, they've already decided they want to have the HIPEC. At the same time, Dr. Lerner published an editorial in the New York Times called The Annals of Extreme Surgery, and really kind of emphasized the challenges of this operation. So what is some of the data around survival outcomes for intraperitoneal therapy? Well, this is a table from a publication looking at all types of cancer: appendiceal, colorectal, mesothelioma, ovarian cancer. And if you look through the literature, sort of looking for the best outcome with intraperitoneal chemotherapy versus systemic chemotherapy, there's no question that if you're giving intraperitoneal chemotherapy, again, in very selected patients, the patients seem to do better with intraperitoneal chemotherapy versus systemic therapy alone. And I recognize that there's a lot of bias in this, these studies looking at this. And when we get together to talk about this at our meetings or at ECOG meetings and stuff like that, it's, this is really the question: where are the randomized control trials for HIPEC? And sometimes it can almost seem like it comes to this at times. Well, there is one really well done randomized control trial that proves that HIPEC can work in the right patients with the right tumor with the right chemotherapy. And this is a study that was published back in January of 2018 in the New England Journal of Medicine in ovarian cancer patients. These were patients with advanced stage 3 ovarian cancer who got neoadjuvant systemic chemotherapy up front, had a good response, were able to go to the operating room, get a complete cytoreduction, and then were randomized in the operating room whether they would get HIPEC or not. And basically, the bottom line was that the ladies who got HIPEC, in addition to the surgery, had a longer progression-free survival and overall survival. Their overall survival was prolonged by a year, which isn't insignificant. So this is really the best study that, again, proves the concept of HIPEC, that HIPEC alone offers a benefit to cytoreductive surgery. I'll just hit some of the high points about the PRODIGE 7 trial, because Dr. Suarez did a nice job of reviewing that. As she said, this was a randomized multi-center phase 3 control trial that was done in France for patients with isolated peritoneal carcinomas from colorectal cancer. As she mentioned, the study was powered to look at an improvement in overall survival from 30 months to 48 months with the addition of HIPEC. This was due to the numbers that would be required otherwise to keep the trial manageable. It took 6 years to accrue all the patients to this trial, and it took another 7 years before the trial was published. So that tells you about the challenges of doing these trials. I'm not going to belabor this, as she already showed you that. But I will point out that, one of the criticisms that has come out of this trial is the fact that the authors used oxaliplatin, which by itself is not a great agent against colorectal cancer. They did give 5-fluorouracil at the time of the HIPEC, but we have no idea if that timing is correct. It was just that's when it was given, and they only gave it for 30 minutes. So remember, I said most people are using 90 minutes to 2 hours. As she pointed out, the other outstanding finding of this study, which makes it a positive study in my mind, was that cytoreduction alone offered an amazing, the patients who got cytoreduction alone had a much better overall survival than was expected. So the authors were expecting 30 months, both groups got 41 months. As you can see, though, there was no proven benefit of the HIPEC. As she mentioned, it seemed like maybe in a subgroup that there was a benefit of HIPEC in this PCI of 11 to 15. But again, this is a subgroup that wasn't planned for. So stay tuned. That might be something, but it's something to look forward to. So Dr. Suarez reviewed the conclusions. The conclusions are that a HIPEC with oxaliplatin does not seem to impact overall or recurrence-free survival. But the cytoreduction alone is definitely beneficial. And so for future directions, what we're looking for in the United States is actually, I've been working with the group at ECOG to put together a cooperative group trial, basically reproducing the PRODIGE 7, but using mitomycin C. As any of you have worked with cooperative groups, you know how things can get bogged down. And right now, this trial is very much bogged down in trying to get everybody on the same page about how this should be designed, but hopefully it will come. This is another trial that is comparing what we call early intraperitoneal chemotherapy versus HIPEC after complete cytoreduction. This is being done at the Memorial Sloan Kettering Cancer Center. This is for patients with appendiceal or colorectal cancer, again, who get the complete cytoreduction and then get randomized to either early postoperative intraperitoneal chemotherapy or HIPEC at the time of surgery. So another interesting way to get at whether or not intraperitoneal chemotherapy, in addition to a complete cytoreduction, offers a benefit in GI malignancies. I just want to briefly show the data that's growing around the palliation of malignant ascites with HIPEC. As you can see here, this is a number of different studies with a variety of different tumors that showed an 83 to 100% resolution of ascites with HIPEC. So it's another thing that we can do to use for HIPEC, and that will definitely fall into something that we think about in terms of palliating symptoms. As Dr. Suarez mentioned, there's very little guidance around how to manage peritoneal carcinomatosis from any cancer. In the NCCN guidelines, there is one sentence for colorectal cancer that says that's specific to peritoneal metastases, that says that complete cytoreductive surgery and/or intraperitoneal chemotherapy can be considered in experienced centers for select patients with limited peritoneal metastases for whom an R0 resection can be achieved. That is it in the NCCN guidelines. Dr. Suarez mentioned the 2018 Chicago Consensus on Peritoneal Surface Malignancies, and I would just draw your attention. All of these had been published in separate articles in the Annals of Surgical Oncology. So there's one for appendiceal tumors, one for colorectal cancer, one for gastric cancer, as you mentioned, neuroendocrine, ovarian, and these are all presented with a flow diagram, just very similar to the NCCN guidelines, but specific for peritoneal carcinomatosis. And so I'm going to end my part of the presentation there, but I would be remiss if I didn't acknowledge everybody that makes it possible for a HIPEC center, a center that does HIPEC to exist. It is truly a multidisciplinary endeavor with everybody, our medical oncologists, our supportive oncology, our GI our gastroenterology colleagues, all the nurses and staff on all the different floors that interact with our HIPEC patients. And I just want to actually give a special shout out to our GI program coordinators who also make this happen. They're the front line for us, greeting these people that are coming to us with a very advanced, serious problem. And they go out of their way, Julie and Nancy and Joanna, to make it as seamless as possible. So I just want to thank them.